Hey, thanks everyone for joining. It's right on the top of the hour, so we'll try and get underway. Thank you, first of all, for those who are joining live, but then there's also a lot of people who've had the opportunity to see this on recording on YouTube or on ISHLT Connect, and thank you also for making the time. My name's Cameron Wolfe. I'm the current chair of the infectious disease professional community at ISHLT, and on behalf of our community and also the pediatric community, we wanted to welcome you to this. We've had a big plan this year to actually make this the first of a couple of webinars centered around the topic of vaccines. That is really our intention, to put this topic front and center on some of the discussions that can happen at ISHLT. We're an international organization, but we've all felt that the issues of vaccines have been so front and center in the media and certainly with all of our patients over the last 12 months that we wanted to allow some good discussion for all of you in this sort of format. So much so that many of you would recognize that there's actually been a society-wide vaccine position statement that has been released a couple of months ago through ISHLT, really to try and, I think, focus our institution, our society, to sort of think about ways that we can all be leaders in our space and leaders in really trying to put sort of clinical decision making around vaccines and vaccine science front and center in the discussion for our patients. That's obviously a little bit of a US-centric issue in recent months, but certainly one that I think will affect all of us globally, and we want to be able to talk about that really front and center. So today, let me first of all thank Emily Eichenberger, a transplant ID colleague at Emory, who's really been a lot of the brains behind getting this together, and her efforts should be acknowledged up front. So we're going to try and do a couple of things for you today. The first part of this webinar will actually be a little more didactic, and then we're going to go into a panel discussion after that. And I would absolutely welcome questions from the audience. You can include them in the chat feature, and all of the speakers will be have agreed to be willing to talk about answering those as we go along, or if some of them come up live, that would certainly be appropriate too. This is recorded and we're all on the same format, so if people can just remember to mute all their video functions on their end of the Zoom, that'd be great. So with that in mind, it's my great pleasure to actually introduce a colleague and a friend, Natasha Halassa. Natasha's professor of pediatric infectious diseases at Vanderbilt, and has had a long career in researching vaccines and implementation science, and is actually going to introduce really a topic very specific about vaccination in thoracic transplant populations as a beginning for this webinar. So Natasha, great pleasure to hand over to you if you're ready.
Can we make sure it's in presenter mode?
I think that controls at your end with your display.
Yes, can you, can you guys, I want to make sure, sorry.
It's currently in the, yeah, you swap it over.
Swap, okay.
There you go, perfect.
Now it's good, okay, perfect, because I could see two screens, so I'm not sure which one you're displaying. So thank you, Cam. It's a pleasure to be here. So these are my disclosures. Also, given the very short period of time, so this will be a very brief overview of respiratory infections and thoracic transplant recipients, and I'm going to concentrate on influenza, SARS-CoV-2, RSV, and pneumococcus, and then we'll talk about the vaccines associated with that as well, but also very brief overview given the time period. So I don't have to tell this audience, but infectious diseases are the leading cause of morbidity and mortality. Specifically with pneumonia and sepsis, we think about strep pneumo, Staph aureus, and respiratory viruses. And since the COVID-19 pandemic, we talk about the triple-demic of co-circulation of RSV, influenza, and SARS-CoV-2. Once again, thoracic transplant recipients, all of you know this, are at high risk for severe illness with acute respiratory infections, and this is due to, in part, immune suppressive therapies, surgical effects of the lungs, and many of these individuals have pre-existing medical conditions like CF or congestive heart failure. Getting a cold for us may not be a problem, but getting an upper respiratory infection with these viral infections can lead to serious complications, including pneumonia, acute rejection, bronchiolitis obliterans syndrome, as well as chronic lung allograft dysfunction. So specifically for influenza, looking at the burden in solid organ transplant recipients, anywhere 1 to 4% of solid transplant recipients are infected annually. In the winter, it can be as high as 42% of upper respiratory and 48% of lower respiratory tract infections. And as we know, the rates are higher in lung, solid organ transplant due to the graft, and liver, and then kidney. And with influenza disease, we can see increased viral load, prolonged shedding, as well as increased development of resistance to antiviral medications. With the COVID-19 pandemic, there was 3 tiers in severity. So you had the first tier, individuals who are not immune compromised, but at higher risk. And then the second tier, those that are moderately immune compromised. And then those that are severely immune compromised, like our solid organ transplant recipients, had the highest risk of severe outcomes related to COVID-19, both in morbidity as well as in mortality. Many of us know about RSV, as well as human metapneumovirus. You see RSV circulates each year in the winter periods. We used to really think about that mostly in the pediatric population. However, great documentation has shown that RSV causes serious illness in adults 50 and older, and as well as hospitalizations, and in those that are severely immune compromised, especially our solid organ transplant recipients. They're also at risk for pneumococcal pneumonia, so not only through age, having their chronic illness as having an underlying lung or heart disease, but also having the solid organ transplant themselves. So when we think about vaccination in thoracic transplant populations, some core concepts to think about: to use only inactivated vaccines, mRNA or protein-based vaccines. Never use live attenuated post-transplant in lung. And I have in quotations heart. My colleague, Dr. Danziger, who's on the panel, has led this, where in pediatrics, they are in certain populations giving live vaccines. And then in pediatrics, we really do think about this, but also in the solid organ transplant community, to think about the household cocooning. So making sure that everyone in the household is up to date on their vaccines, as well as getting their influenza vaccines yearly. So it's really an exciting time for viral vaccines. For a long time, we've known about the flu vaccine, but with the pandemic, we have COVID-19 vaccines, and really exciting, we actually have RSV vaccines, and we'll touch on that later. But I think when you look at standard vaccines, especially in influenza vaccines, vaccine responses in solid organ transplant recipients are lower when compared to healthy controls. And so in this one study where they looked at 43 lung transplant recipients and compared them to 21 healthy controls, here on the first one is looking at humoral responses with protective titer defined as 1 to 40, and the percent that achieve it. And then the other one is a 4-fold rise. And then looking at the 3 influenza strains on the x-axis. And so you can see in white, those are the percent for lung transplant recipients. And when you see the diagonal shaded, those are the healthy controls. You can see very easily that lung transplant recipients do not respond as well to the standard influenza vaccines compared to healthy controls. Interesting enough, and then when you actually look at what immune suppressive medications they are on, they found that cyclosporin was associated with lower responses. So the white is none of the antigens had a seroresponse, and you can see it's much higher in the cyclosporin group compared to tacrolimus. However, in a nice study that was done at led by Dr. Kumar, who's in Toronto, they looked at 477 solid organ patients confirmed with influenza over 5 consecutive seasons. The median age was 5. They did include 25 pediatric subjects, and none of them had died. And what they found, that actually getting the influenza vaccine compared to not getting the influenza vaccine, you had a decreased odds ratio of getting pneumonia, and you were less likely to be admitted to the ICU. So even though you don't respond to the standard flu vaccine as well, it's better to get the flu vaccine than to not get the flu vaccine. So what about some alternatives? And so what about high-dose influenza vaccine? So the difference is there's 15 micrograms of each antigen compared to the high dose, which has 60, so 4 times the antigen dose. When looking at 65 years and older, the elderly population, and they looked at flu vaccine standard and compared it to less than 65, they found that those that were over 65 did not respond to the flu vaccine. So they wanted to have an alternative. And so they came up with, Sanofi did, the high-dose influenza vaccine, as we said, is 4 times the antigen dose, and compared it to standard dose in those that were 65 years and older. And it was a trivalent vaccine, so you can see 2 A's and a B, where they had high dose compared to standard dose, and they randomized in a 2-to-1 fashion. When you look at the geometric mean titers, you can see that they're higher for all 3 antigens compared to standard. And then you take the ratio. So you divide 116 divided by 67 to get a geometric mean ratio, and it was 1.7, and it was 1.8 for H3N2, and it reached statistical significance of greater than 1.5 and above, and this led to the licensure of the high-dose flu vaccine. And so not only do you get higher antibody titers, they did an efficacy trial where they enrolled over nearly 32,000 subjects and evenly divided between the high dose and the standard dose. Those in the high dose group, 1.4 confirmed influenza compared to the standard dose was 1.9. So it gave it a relative efficacy of 24%. So not only having higher antibody dosage, they were 24% less likely to get confirmed influenza. So led here, first off the Notori, but this is out of Dr. Kumar's group. They did a single center randomized double blind study where they also thought, well, if the elderly don't respond to the flu vaccine as well, what about solid organ transplants? So they compared 1 dose of high dose TIV to 1 dose of standard dose TIV. The median age was 57. Even though they enrolled as early as 3 months, you can see the median time to transplant was 38. So it's really in the late transplant period. However, they were still able to show that the high dose group, which was 84 subjects compared to the standard dose group, which was 77, had higher antibody titers. And when they did the ratio, they showed that it was 1.64 for H1N1 and 2.6 for B. So once again, showing that 1 dose of high dose was superior to 1 dose of standard dose in the solid organ transplant population. Another group looked at in-season boosting, so looked at 2 doses of standard compared to 1 dose of standard. And it was a multi-center study, open-labeled, randomized control that was Cordero in Spain had led. They enrolled 499 subjects, so 1 versus 2. The median age was 56, very similar, and they went down to 1 month. However, you can see once again, the median time to transplant is 18 months, so more in the later transplant period. They also showed that the geometric mean titers were better with 2 doses compared to 1 dose, and that the ratio was 1.8 for H3N2 and 2.1 for influenza. So another alternative. The IDSA guidelines are actually 2013. They're in the midst of going through and updating it, but the ones that are published now said 1 dose in individuals 6 months and older, starting at 2 months. But if you're in an outbreak, you can start as early as 1 month, but they only recommend 2 doses if you're less than 9 years of age and it's the first time you're getting the flu vaccine. The American Society of Transplantation with Dr. Danziger as one of the lead authors. They recommend 1 dose of the inactivated vaccine in greater than 6 months of age, starting at 1 month after solid organ. And based on the 2 studies, said either high dose or booster dosing in the same season has greater immunogenicity and may be preferred over standard. So limitations of these solid organ studies, primarily adult studies with the predominance of kidney. Pediatric studies were limited in size and organ types, limited vaccination in the early transplant period, limited assessment. They didn't look at durability. And what we don't know is 2 doses potentially superior in the first season compared to 1 dose. And so something that our group has been doing for the past almost 15 years now, looking at high-dose flu vaccine versus standard dose, we've already published that in pediatric and adult stem cell transplant recipients in the early transplant period, getting 2 doses of high dose compared to 2 doses of standard is superior. I'm going to show you, after we all met, we found out and looked at the literature and showed that the early transplant period is limited and we don't know what's optimal. And so we did heart, kidney, and liver. And we just finished enrollment last year. Dr. Wolfe was also a site PI for this study, and we enrolled 396. So we hope to share some exciting data in the next 6 months, where we randomized 2 groups, 3 groups. One got 2 doses of standard, one got 2 doses of high dose, and one got just 1 dose of high dose. So hopefully the next seminar we'll be able to share the information. Then our lung transplant recipients, our lung transplant physicians said, well, what about our lung transplant recipients? They have the highest risk of influenza disease. Please study it. And so this is our 4th year looking into lung transplant. So we hope to finish enrollment this year. And you can see all the different sites, including Dr. Wolfe. So we're excited, hopefully, and maybe in about a year to tell you some results of its 2 doses of high dose better than 2 doses of standard. And then co-PI with Dr. Danziger, we are also enrolling the pediatrics. So we'll give you some information on our kidney, heart, and liver as well. So COVID-19 prevention, we know that social distancing, hand hygiene, and masks are ways to protect our patients, but we definitely do not want to shut down the world again. And so all of us were incredibly excited when 2 mRNA vaccine worked and had 95% efficacy at preventing COVID-19 illness. All of us know they excluded our solid organ transplant recipients. And so when people started to look at it, we found that there's reduced neutralization in the immune-compromised host, but it's actually not equal. And so this is a really nice schematic that shows the different populations. And you can see in the solid organ, as low as 20 to 50% of them had, compared to healthy controls, a good response. And this is another way of looking at it. So the dotted line at the top looks at healthy controls, and then looking at the percent with an antibody response and looking at the different ones. And you can see with the solid organ, they have some of the lowest percentage of responses. And our group, just like many other groups, took advantage to look quickly at the solid organ transplant participants. And we also enrolled healthy controls. The antibody titers are on the y-axis, baseline, and then 1 month after post dose 1, and then after 1 month after post dose 2. And you can see in blue, nice increases in the healthy controls, but after 1 dose, not as many response, but even a little bit better after 2 doses. Once again, just like flu vaccine, this nice study that came out of England showed that the highest mortality in COVID-positive patients in solid organ were in the unvaccinated, but it came less when you had 1 dose and even lower when you had 2 doses. So once again, some vaccine was better than none at preventing severe illness. So in the US, we have Moderna for the 25-26 formulation. So there's 2 vaccines that were approved, and Pfizer has 1, and Novavax has a 3rd. And I'm sure many of your patients, we are doing a vaccine study, and we're looking at how many COVID vaccines are transplant recipients, and some of them are now on number 8. More questions for the future. How many higher doses? What should we be doing? So, and then another really exciting thing in 2023, 2 RSV vaccines were approved. Abrismo, it's a bivalent subunit vaccine. unadjuvanted, made by Pfizer for 60 plus, as well as 18 to 59 in high risk, as well as pregnant women 32 to 36. And then we have the GSK vaccine, which is bivalent subunit vaccine. This one is adjuvanted, and it's 60 plus or 50 to 59 in high risk. And then in 2004, which was exciting, the mRNA vaccine for RSV by Moderna, 60 plus, as well as 18 to 59 in high risk. And those that are pediatricians, we're incredibly excited about the monoclonal long-acting antibody due to the YTE modification. You only need one dose instead of the palivizumab that needed monthly doses. And this is in the first year for all infants less than 8 months of age, and then in the second year for high-risk individuals. And we've already seen that it's the effectiveness is really great, and hospital rates are going down. And another long-acting clesrovimab is for infants in their first season that just approved. So there's been a few studies out there in immune-compromised hosts that this one came out of Hopkins, once again showing that the RSV vaccine does not respond as well in your immune-compromised host individuals. 40% of them here did not have a response. The question now is, if they need a second dose, when do they need a second dose? In this study where they looked at baseline and then time since vaccination, you can see that the antibody titers are staying around the same, but the question is, do they need a boost? And then they had a hint potentially that the adjuvanted having a little bit higher responses, but the sample size is really small and it's not powered for that. And so that's another question. 2 doses, yes or no? And is one of the platforms better? So that's one thing that we will be submitting a grant to the NIH and comparing all 3 platforms. Pneumococcal vaccine, we know about the 23-valent, but that's unconjugated. And for children less than 2, they didn't respond to it. So it was super exciting when we had a conjugate vaccine. And when we gave it to kids, we actually protected adults indirectly. But there are immune-compromised individuals that do need that direct response and direct vaccine to themselves for protection. And the exciting thing is it went from a 7-valent to over time now we have a 21-valent. And then there's a nice thing that shows with the immune-compromised host, if you haven't had the PCV23, you want to go and give direct PCV21. If not, you wait a year. And then this goes through depending on which one they were exposed to. Dr. Wolfe talked about the statement. I saw this online and I thought we'd highlight it, that vaccines are important in transplant recipients. There's a lot that we need to do, and just a reminder for everyone to get their flu shot. And I'll stop there.
Hey, Natasha, thanks so much. We gave you probably the hardest task to talk about vaccines in a 15 to 20 minute overview. So I appreciate you focusing in there on some really key points that I hope will really come up in our moderated discussion. I'm going to hand it over now to my colleague, Dima Kabbani. Dima, I'll let you introduce yourself. Dima's going to present a case and then we'll walk into a more open discussion.
Okay, so I'm Dima Kabbani. I'm an assistant professor at the University of Alberta, and I'm an adult transplant ID physician. So these are my disclosures. Okay, so I'll start by sharing a case with you. So this was an 80-year-old boy, end-stage heart disease secondary to dilated cardiomyopathy that was presumed related to a viral infection. He was diagnosed when he was 6 years old with progressive heart failure symptoms, fatigue, dyspnea, and poor growth, had recurrent hospitalization for decompensated heart failure, and then was listed for heart transplant, had not had any significant infection. He was referred to our pediatric transplant ID colleague because he was noticed to have incomplete immunization record. So his parents had declined MMR, varicella, influenza, and COVID vaccine. And when he was seen in clinic, the parents had actually several concerns that they brought up with my colleague on why they did not want to vaccinate their child. And these are some of the statements they had. So the first one is that mom worried that giving him so many vaccines could overwhelm his immune system, and the child was already so weak. The other concern was related to MMR and autism. So she's already read many stories about kids developing autism after getting vaccinated, and she had seen it in her neighbors that swears that their child changed after they've received the MMR vaccine. And finally, it felt like all these drug companies just push vaccines for profit, and how do we know that they're really safe? So I'm gonna stop here and ask one of our panelists for some question. I'm sure Dr. Dazinger sees these pediatric patients much more than I do and sees similar scenario. So Laura, how medically important are these vaccines for these patients to receive? And then when you are faced with these scenario, how do you have strategy that have been effective in counseling the parents for their child to receive vaccinations?
Right. I think part of the counseling starts with identifying to the patients and the parents the imperative of how important these specific vaccines are to protecting their child. We've unfortunately and fortunately had the experience of a measles resurgence recently, as well as many outbreaks of pertussis and varicella in the past several months to years. And that has also raised the profile and the understanding that that there are safety issues with kids who want to live full and complete lives in the before transplant as well as after transplant, and identifying this so patients and families can make better decisions around understanding what the true risks actually are. There's also some great data from pediatric and adults both that was led by Dipali Kumar several years ago around influenza vaccine and identifying that if you are vaccinated, if you're a transplant recipient and you're vaccinated, your risk of significant morbidity and mortality substantially declines, and letting people know that that information exists and is real also helps that conversation, because then people understand that we're not just pulling things out of the air and making suggestions willy-nilly, that we're basing this on experience and data that actually is directly related to their child's experience. As far as tactics, actually, we start our conversations, and there's great data in pediatrics using some virtual reality training, that starting your conversations with presumptive language of your child needs these vaccines today. These are the vaccines that they should receive today, is a very, very good way of introducing things so that the table is set and that they understand that this is part of the process and the expectation, without telling them that they have to get the vaccine. It really gives them the idea that you appreciate the importance of it and sets a framework for the patient and the family that this is part of the care to optimize their ability for their child to live their best life once they have their transplant.
Laura, I love that answer, and it sounds like it's obviously a topic that you've had to think about, repeatedly in front of most of your clinical patients. We heard a case there that was topical given measles that's occurred in North America, but we've got speakers here who are also intentionally outside of the US. And I was actually going to turn to Jacob to bring you into a conversation. Jacob, for those that don't know you, maybe a quick one sentence introduction for yourself.
I'm Jacob Sims. I'm a pediatric cardiologist and transplant physician at Great Ormond Street in London. And coming from the home of Edward Jenner and vaccines, it's a little bit difficult to talk about vaccines in the UK. We have a special relationship, particularly with a small minority who have vaccine hesitancy. And we were speaking earlier, Cam, 20 years ago, vaccine hesitancy was the realm of wealthy, educated people. And over the course of the last 20 years, actually, that paradigm has shifted. I think that's been with the advent of social media and some of the difficult conversations that are out there for sure. And also an increasing distrust of medicine in general amongst people who feel maybe disengaged in some way. So to the point of vaccines in particular, they are handled with really kid gloves across the UK, and that's not just transplant patients. And one example is that for every other medical procedure or treatment in the UK, if one of your parents says they will consent to the treatment and another parent says I won't consent to the treatment, that's fine. We can do that operation, we can give that treatment. Apart from vaccines, if one of your parents says, I don't want my child to have a vaccine, it is not allowed to give the vaccine to the child if the child wants it or if the other parent wants it or both. So we do have a slightly hands-off attitude to people who would rather not have vaccines. Laura's answer was excellent, I think, and that's exactly the way that we would come to talk to a family and try and educate a family around vaccines and talk about the importance of vaccines in general, but specifically, of course, in transplant. But we have never got to a stage where we would consider vaccine hesitancy in any member of the family as a reason not to list for transplant. I think that would be very controversial in the UK, and particularly in the pediatric sphere, where it is likely that it is the parent who is saying no to the vaccine, but it is in shorthand terms, it is the patient, the child, who will suffer from our change in policy.
Maybe a question to all of the pediatricians, if I can jump in there. Like, this case was that Dima presented was one where a viral illness, in fact, led that child to the transplant table, so to speak. Are there different techniques that can be effective or that have come up that have been helpful for you when talking about vaccines in that context? Because that sounds like a arguably even more rigidly held position by that family if their declination is in that context.
Yeah, I think one of the really important things is, yes, while the child had a viral illness that, unmasks some, underlying genetic cardiomyopathy, you have to be really careful about not ascribing a blame to this family for what this child has gone through. You really want to ensure that they realize that yes, there was an opportunity to vaccinate, especially if this is a vaccine preventable illness that induced this. They had terrible influenza or something to that effect, which we often see, that kids come in and they have terrible influenza and their lungs are horribly affected and they end up needing a lung transplant. And that is a terrible consequence, a terrible outcome, or some other illness that they get a super infection after having a pertussis infection in a young child. So you want to make sure that you're not, burdening the family with a second guess. You want to make sure that you're supporting them and making the best decisions they can as they move forward, taking care of their child, and ensuring that they, appreciate that. There are some patients and families where it's very challenging, and no matter information that you give them and share with them and show them, they want to read articles and they want to see what you're talking about, sometimes you can't really move the needle. And you do the best you can by arming them with the information and documenting that you've done that. But also, repetition. Once someone says, I don't want to do the vaccine. It's more like, you know what, this is a long-term conversation. We need to have an ongoing conversation because I've had patients that refused vaccine pre-transplant. And now that there's actually a measles outbreak and has been in our area, they've come back and said, you know I'm post-transplant now, but this feels more real, and am I eligible for this vaccine? And I think that giving people the door so that they can reopen of the conversation, asking them every visit, not in a punitive way, but in a way that says, we think that this patient is due for X, and we would like to offer that to you, and we know, and sometimes they'll say, we've had patients who've said, please stop asking me, and we respect that, obviously, but also we also know that repetition and that underscores our commitment to keeping the patient safe, and that's how I start every conversation with every patient from the time they are evaluated pre-transplant. My goal is to help you live your best life for as long as you can, and not to tell you not to do things, but to give you the tools to do things more safely. And I think that that's really an important kind of attitude to have with a patient and family.
Thank you, Laura. I like the continuity. I felt that during the COVID area, when we were discussing with some patients, I've had some that have booked on multiple visits, and it's just with discussion that we have moved the ball. So I'm going to move on to the adult and ask Peter Hopkins if this was the same scenario in an adult lung. How would you have handled this?
Yeah, thank you.
And Peter, if you want to just introduce yourself before we start. Thank you.
Thank you. Yeah, so Peter Hopkins, I'm from Brisbane, Australia, and I'm Executive Director of Heart Lung here in Metro North in Brisbane. Really interesting discussion. And in the adult population, we are fairly strict. So we do have a mandatory COVID vaccination policy. What has helped that is we have a national governance group in lung transplantation called LTAC, and there's 4 transplant programs in Australia, and we have reached consensus on this, and we have a minimum requirement of 2 COVID vaccinations for patients prior to listing for transplant. What has helped that is that we've been very transparent with the patients, because we have been caught out where they have invasive testing, angiography, colonoscopy, and then someone says, oh, actually, you've got to be vaccinated as well. So, we've learned from that. And so literally in the first consultation, when they're referred, we say that this is our policy. It's in all of our education material, our transplant booklets. And so we're very upfront with that. But that is a universal policy for the country. Also helping that is we do have a government body called ATAGI, which makes recommendations every 6 months, and they update the recommendations for vaccination. And so we literally reference that expert group in all of the information that we give patients. To be honest, very rarely have we had an issue. I mean, occasionally we get patients who absolutely refuse and then write letters and make complaints. But I must say it is pretty unusual.
That's great, Peter, actually, to hear such consensus across the whole country, because that must have taken some effort to get to that point. Can I push you on that a little bit? Does that consensus hold now 5 years into a pandemic? How does that play out?
Yeah, it's interesting because the ATAGI recommendations have softened over time, and we're very respectful of that. And so we literally have, up until fairly recently, it was, and you need a COVID booster. But to represent the softening of the language in the ATAGI document, we have purely reflected what is in that document. And so that's updated every 6 months. If it comes to a time where that is less sort of rigid, then I think I'd be pretty confident we'll reflect that. I really want to state that having all the programs have the same policy has really helped. So no one's isolated. and we're very fortunate that we've had that sort of consensus. I think that's been a big part of it.
I'm sure it absolutely helped. Olivia, let me bring you in. That seems to be a really good dovetail. You may introduce yourself really quickly, and then I'd love to hear your thoughts on that, because something that Peter mentioned there was sort of a nationwide requirement. There's obviously an ethics here too that plays into transplantation and things that we require of our patients. Interested in your thoughts as to where that plays out, particularly in relation to Dima's case.
Sure. Yeah. So I'm Olivia. I'm a transplant infectious diseases doctor and bioethicist at Johns Hopkins. So I always enjoy hearing from Peter Hopkins. But I would say the story in the United States has been almost the opposite of what you described, Peter. We did not have consensus about vaccination practices or requirements, and we still don't. And so earlier in the pandemic, we saw programs implement and then retract vaccination requirements. We saw neighboring programs with radically different policies. We saw national organizations maybe hesitant to make any sort of prescriptive comments about vaccine mandates or requirements in transplantation. And so we continue to have a very uneven patchwork of vaccination policies, even to the point that within a single center, different transplant programs may have different policies, and different members of the transplant team may have different understandings of what the policies are or where they might or might not be recorded. And I think that led to a lot of problems in trying to see these policies through. And I think that there's been a big trend toward retracting vaccination requirement policies in centers that quickly rolled them out and quickly rolled them back related to COVID-19. Most places thought that the ethical justification for requirements was really related to maximizing the net utility from transplantation. So organs are scarce. We want to have good outcomes. Vaccination supports good outcomes. It has the added bonus that it's seemingly very easy to do, so why not? That justification is clearly really context dependent, right? Because the impact of vaccination on the net utility from transplants is going to vary with disease prevalence and severity and the availability of alternative protective measures. And having a justification that varies so wildly with even week to week, perhaps changes in epidemiology, is also very tenuous, right? It's not really practicable to rehash that policy every time there's new information, which is every single day. Some of the other justifications that emerged was like a social contract justification, saying that the transplant patients or candidates sort of owe it to each other to all be doing their best as members of the transplant community. We do see sort of national or international policies lean on these like transplant-specific pro-social behaviors in selection and allocation. So we have the Declaration of Istanbul that for a while advised against listing candidates who had previously participated in transplant tourism, transplant-specific, not pro-social behavior. And we have additional sort of allocation points for candidates who've previously donated organs, right, to transplant-specific pro-social behavior. So it's possible that this social contract justification is more useful and then doesn't work for Dima's case because children are not subject to the contract in the same way.
I'm gonna go back to Laura and ask a different type of question. So some of our pediatrics patients, cardiothoracic patients and heart don't get a chance, for example, to get vaccinated, or their parents refuse, and they've not been vaccinated for measles. But then we're seeing them at 19 or 20, and the child is now interested in taking measles vaccine, but he's or a varicella vaccine, but he's now post-transplant. So how do you approach that same child that's now 18-year-old?
Right. So this is an active area of interest and investigation. I would say this investigation started, I'm going to go back into the 2010s, when a group in Switzerland started giving a varicella vaccine, and then actually MMR vaccine, clariphosphate barb, and others in that group started giving that to their liver transplant recipients who were on monotherapy at low dose with tacrolimus. And they had good outcomes as far as safety and some immunogenicity data. This was, followed over time by, acknowledgement that other people were doing this clinically. And then there were some other larger discussions around it. There was a consensus conference for pediatrics, which included young adults, and some parameters set into place for, who would probably be considered. They used a red, yellow, green differential of, vaccinate, consider vaccinate, don't vaccinate. And I will say that initially hearts were in the don't vaccinate category and lungs as well. That has shifted, and I think that shifted through not experimentation, I would say through challenging the perceptions around what is okay, and some people who really thought very carefully about the immunologic status of their patients and decided to have a lot of shared decision making with their patients and their families about trying to vaccinate in more extended immunosuppressive regimens. This started with livers, where we started doing vaccinations for patients who were on 2-drug therapy, who were on higher doses of immunosuppression, some patients who were on other biologics, and the like. There have been a couple papers published in the last few years that showed that in livers and kidneys, this also had a good safety profile, had good immunogenicity. Ann Dipshan in Toronto started doing this with her cardiac transplant recipients, especially because they have a large volume. They've done a lot of ABO incompatible transplants. They pioneered that work. And so she had a lot of patients who were transplanted very young. And she started with varicella, which of course we have a rescue drug in case patients do get varicella, and followed that with doing some studies in measles, and she's shown good success. With the measles outbreak nationally, we have had many centers who are working toward this. Our center is one of them, where we vaccinated almost a dozen kids with chickenpox or measles vaccine, with Varivax or MMR. And we're, trying to base the decision making around who to give vaccine to based on extrapolation from our experience with livers and kidneys. So that has paved the way, and more centers are doing it. There's a national collaborative collecting information about this, and it is in young adults, generally under their early to mid 20s and younger. We certainly don't vaccinate patients who've recently been unwell or had recent rejection or got augmented immunosuppression, or who are on medications like belatacept or other things like that, due to or JAK inhibitors for that matter, because of the risk of propagation of viral disease. And so I think that that's something that really needs to be considered. In the adult population, number one, this may be different. Absolutely. If a child had been vaccinated with 1 dose of chickenpox previously, or they had had a natural disease before their transplant or after their transplant for that matter, and they're over the age of 18, they can get a subunit Shingrix vaccine, which is not live. And so chickenpox is kind of off the table. But then you talk about MMR, and you run into patients who are in their 30s or 40s or 50s or maybe even older. And the question is, what do you do with them? Because they have a different immunologic profile that we really haven't interrogated in the same way. And that really does require study. And I know that there are some people that are doing that investigation currently, trying to extrapolate even further, maintaining safety and a safety profile while assessing immunogenicity in that population.
Thanks, Lara. I mean, I agree. That's a huge call for a study in the adult population. The question comes up all the time. You mentioned sort of measles, and I think, Olivia, you had sort of mentioned the ebb and flow of disease states. Jacob, I was fascinated by your comment about how parental control dictates UK decision making. Maybe an unfair question, but can you comment on how that might influence your clinical practice if, like, our US issues of measles became front and center for you in the UK?
Yeah, it's a real threat, Cam. We've had outbreaks of measles certainly over the last 10, 15 years due to low uptake of the MMR vaccine. Again, another thing that generated, I think, from the UK. And I don't really know what we would do for the post-transplant patients. We've certainly taken a much more active role in trying to get MMR into our children who are on the transplant waiting list, to the point where we will suspend people from the transplant waiting list, but usually we say two to 3 weeks while we give them an MMR vaccine if they've been listed for transplant, usually at an age prior to when we give MMR in the UK. That's at 1 year of age. So I think we have already started to wake up to the fact that we are walking towards a potential bad measles outbreak. We just haven't had it yet. I thought Laura's answer was really fascinating, really about the move towards the possibility of giving live vaccines post-transplant. And I think that's probably where we'll go. But the other side of this equation, and particularly when you're talking to a family who are slightly vaccine hesitant, is that we don't see a lot of these diseases causing serious harm in our patients post-transplant. The thing that we see the most is non-immune children to varicella coming in contact with friends or brothers and sisters with varicella, and then you have to take them out of school, and we have to give them acyclovir for 14 days, and that's a pain. But that's as far as it's gone. We haven't actually had a serious illness yet. That's 600 transplants in.
Peter, I'm going to ask you maybe to answer the question in the chart that was asked by Eric. You have your hand up, sorry.
Oh, sorry, I'll look at that question, but just had a question for the group about occasionally we get pre-transplant patients, they're varicella naive, and we give them the live vaccine, and we're always debating as a group, how long do we, defer their active listing, given that it's an attenuated virus? And look, we sort of land somewhere around 3 to 4 weeks, but do you think that might be excessive? And often they are the really sick people, and you sort of, you want to make a decision to list them. I'm really interested in hearing what people think about that.
Lara, you've got your hand up. Do you want to tackle it first?
Yeah, I'm going to tackle it first because there's actually some data about this now. It's a very small study, but it is a study that was done, prospectively. They actually looked at very small pediatric liver transplant patients getting vaccinated and monitored for varicella or measles after the vaccine, and looked at viral replication in the blood to see how long it lasted. And they looked in healthy people, and they looked in kids who were on the waiting list. And actually, most of them all clear by about 2 weeks. So, especially when you're talking about people who are quote unquote, have not been vaccinated and are considered naive, but they say, oh, I think I had chicken pox, but they're serologically negative, which we do see a lot of, actually. You could probably collapse that period a little bit. Also knowing that, you do have rescue medication. So occasionally we'll have a kid who will get a varicella vaccine, and a perfect organ offer will come up, and they haven't been getting offers, and it will come up on, day 7 or day 8. Or day 10, and we will just plan to give them antivirals in addition, and say, potentially wasted vaccine, but we'd rather get a really excellent organ for the patient.
Peter, I think Eric both has his hands up, but has a great question in the chat, which if you can't see it, I'll read it. It's really about how does your policy apply if you knew someone was strongly seropositive? Does that influence that decision? And that was
I knew someone was going to ask me that. And look, we do check COVID serology. For us, it doesn't make a difference because our feeling is if they've got hybrid immunity, our feeling is that's a very powerful layer of protection. And so I think it doesn't influence our decision. And I think that's a nationally consistent approach as well.
Eric, if you had a different question, you want to come off mute, feel free.
Yeah. Well, the question is, if you sometimes you have patients you need an urgent transplant, so you vaccinate them, and then just like Laura said, well, you get an offer a few days later, and you're afraid that you just boost the immunity, you activated, let's say, the cellular response, and then you're going to give T-cell immunosuppression or might even give induction therapy. Aren't you afraid that you rather wipe out the specific immunity against a virus or just the pathogen that you have vaccinated? Do you give, for example, ATG induction therapy shortly after you vaccinated the patient? I would be hesitant to do so.
I think if it's the right opportunity to transplant, and we've, I guess, made the innocent mistake of ill-timed vaccination, a patient needs ATG because of the risk of rejection, so be it. And then my intention would be to revaccinate with vaccines administered within less than 2 weeks before ATG in the future.
Okay.
We do have a question in the chat here from Eric, a different Eric, which is a great one, and I'll put this open to anyone who wants to tackle it. So, with increasing numbers of Fontan patients being listed with protein-losing enteropathy who may be immunodeficient, is there a CD4 threshold that we would be feeling safe pre-transplant to give living vaccines?
This is a great question. It's a great question, and I would say for kids, and I mean, I guess this could be an adult, but we often see this in kids where they have protein-losing enteropathy, and generally we see that they have low immunoglobulin levels, but they don't necessarily have low CD4 counts. We generally use that we want a patient to have an age-appropriate absolute lymphocyte count, and that is our threshold for most of our live viral vaccines, regardless of if you're before or after transplant. And recalling that for younger children, that normal absolute lymphocyte count is much higher than it is for an adult.
That right there is the reason we had pediatricians engaged in this webinar from the outset, because I think the adult answer would be extremely difficult. And Eric, to answer your question, I would engage HIV literature to perhaps look at CD4 count relevance in regards to living vaccines, where I think we have a slightly richer sort of non-transplanted experience that would be helpful there. We're coming up on the hour, so I'm actually going to take the chance if speakers would, I'm going to challenge you. You know, you're all involved on a daily basis and having these conversations with patients. We all are. Is there a single nugget that you use that you find really helpful when you're having these conversations that our listeners can sort of take away as something to clutch onto that they might use themselves in front of patients? Peter, I'll start with you only because you're in the middle of my screen.
Well, Cameron, I think for us, it's definitely very early conversations, literally at the first consultation, just so the expectations are set. It's in your education material. It's handed to the patient. So there's full transparency. I think that would be my take-home message.
Olivia, do you tackle it differently? Something to take home?
I mean, I will add what I have found to be most successful, since we don't really have the background of a nationwide policy to be transparent about. I'm really in the position of persuading people to accept vaccination that is not necessarily required of them. And I think what is most likely to be successful is positivity and enthusiasm. I think our patients do not like to feel like we dislike them, or like we think that they're not smart, or like we think that they can't understand. I think they like to feel like we enjoy taking care of them, which we do. If we forget that when we're talking about vaccines, it makes vaccines the least fun part of their time with us, when really it should be the most fun. So I think even if it's a disagreement, we should be enjoying it with them.
Natasha, I can see you nod your head there on
It wasn't
this.
a transplant patient, but it was a Downs patient, 9-month-old that was unvaccinated and got admitted for pertussis. And so it's seeking to understand where the parent is coming from, and trying to approach it that I know you want the best for your child just as much as I want the best for your child. And where I'm coming from as an infectious disease, I have to tell you my point of view. And with 24 hours, she didn't like me, but within 48 hours, we're hugging. And so it's one of those things that I really like to Olivia said, that is that like just coming at saying, I'm trying to seek to understand where you're coming from and your thought process. I may or may not be able to change your mind. However, we all have the same goal. We want the best for you as the patient, you as, if you're a child or an XYZ. And so just trying to not put judgment there, but always trying to like seek to understand. And sometimes we're successful, and sometimes if they have thoughts and it's like, I can't change if you think that there's poison in the vaccine and and your sources tell you that, and but just try to come back with facts. And so
Jacob, any last comments?
Yeah, I mean, everyone said great things, particularly the empathetic approach of Natasha seems sensible. But I think one of the sneaky things perhaps we do in London when we're faced with this is we're wrapping it up with transplant assessment and listing in general. We can be very dogmatic about the fact you've got to take your tacrolimus and your MMF. We can be quite dogmatic about the fact that you've got to have blood tests to check your tacrolimus levels, and you're going to have echocardiograms every time you come. And they're not always easy for all of our patients. Children don't like having blood tests. They don't like having echocardiograms. It is very rare for a family to say to us, oh yeah, we wanted transplant, but now that we've got to have blood tests, or now that we're going to have to take the tacrolimus, we're not going to have a transplant. That doesn't happen. So I think that's a door into this conversation of, there are lots of things that we don't want to do to you, but we're going to have to do them to you. And then if you can bring in the vaccines at that stage and say, we notice that you're unvaccinated at the moment, but actually what we're looking at is putting you in an even more vulnerable position. And we recommend strongly that all of our transplant patients get vaccinated as part of our assessment and getting you onto the transplant list. And I think that is a way to maybe get people to look at it from our point of view a little bit more, when they've already accepted the fact that they're going to have to buy into the transplant program and buy into taking medicines twice a day, every day for the rest of their lives, and buy into a stenotomy and intubation and chest drains. All of a sudden, the vaccination thing tends to calm down a little bit.
Terrific answer. Dima, you posed the case up front. Do you want to close us out with your thoughts? And then we're right on the hour.
Sure. I mean, everybody has brought some great points, and our centers, what I've find helpful is at the same time, before, like when they're candidate, the same information you give them about immunosuppression, you send them a list of these are the vaccination, and you would discuss with them. And our public health is great to give them also more information. I think all the points that have been given are great.
Well, I appreciate everyone for joining. We've just snuck past the hour. Like I said at the beginning, we think this is an important topic to continue to have a sort of science-forward conversation, a clinically patient-centric conversation, because it's the right time, I think, to push back a little bit on otherwise a public message that's been a bit negative this year. So thank you all for joining. Again, look out for a webinar 2.0 in the new year, talking about some different vaccines. But otherwise, thank you, and wherever you are, have a good rest of your day.